I've already discussed diabetes today, and what I'd like to do is to return to part of the prevention factor, the blood pressure, as we hearing about cholesterol as well. Okay. So what I'd like to do is to focus on goals, but in so doing, address the issue of definitions. I think we all have to agree we have to appreciate the epidemiological relationship between blood pressure and cardiovascular events, to realize that we lack data from randomized controlled trials to know the ideal systolic blood pressure for reducing events, although, as I mentioned this morning, we do have the ongoing SPRINT trial. I'd like to emphasize again the importance of the systolic once you reach the tender age of 55 years, which I now define as middle youth. And then I'll focus on issues surrounding specific drugs. We certainly have data with the renin-angiotensin system blockers providing a 20% relative risk reduction benefit in people with established heart and kidney disease. And of course, the big question is, can we extrapolate forward to look at people without evident disease? Many people ask, where did the number 140/90 come from? Believe it or not, it came from life insurance adjusters looking at actuarial statistics. There's absolutely no science involved at all. There are many systems that regulate blood pressure, and certainly these come into play when we consider treatment strategies. We have the sympathetic nervous system, which is obviously immediate, the renin-angiotensin system, which can start to work in minutes to hours, and of course, the kidney is the final regulator of sodium and water balance, and that may take hours to days to kick in and influence blood pressure. And these systems work very well in health. The sympathetic nervous system has a series of afferent signals, which then send out efferents, and you can see them shown here. Again, various stretch receptors and baroreceptors send signals to the central nervous system, and then the resultant effects are shown here. Certainly, abnormalities in how this system functions can alter blood pressure responses. Likewise, the renin-angiotensin system is a very complicated system, far more complicated than what is shown in this very simple figure. Again, this also involves a combination of angiotensin II and, of course, aldosterone. And this broad system affects all of the various target organs in the body. And, of course, we have the pressure natriuresis shift, which we tend to see changing with middle youth, so that, in a sense, you need a higher ambient pressure to facilitate a specific amount of output of salt and water. And this we call salt sensitivity, which tends to happen to all of us with increasing maturity, largely dependent on environmental factors, but also our heredity. But one of the probing questions that comes up with all of these systems that regulate blood pressure is, why do blood vessels change in time? Is it a mechanical effect? Is it a humoral effect? Or is it a combination of the two? And theoretically, you wonder whether or not you can prevent this progressive process from looking like this. Because if indeed it is mechanical, in part, you should want to prevent blood pressure escalation with age in order to prevent your vessels from looking like this. So waiting for blood pressure to rise to a certain level before you deem it necessary to treat may in fact be an incorrect thought process if indeed you have the genetic factors for developing higher levels of blood pressure sooner in life. Now, where's some examples to indicate that? Well, this is a paper published last year which looked at blood pressure trajectories in early adulthood with the development of subclinical atherosclerosis as defined by coronary artery calcium scores. And this comes from the Cardia study, nearly 5,000 people who are extremely young. It's looking younger and younger to me every passing years. Even my children are starting to grow out of that age range. You have 25 years of follow-up. And basically, they defined 5 different mid-blood pressure trajectories. And as you can see, the steeper the slope of change of blood pressure, the greater the likelihood of having a coronary artery calcium score greater than 100 units. Graphically, we can depict it like this. And certainly, as you look at the systolic blood pressure changes here, and again, the majority of this time frame is in the under 140 period, one would have to agree that there's something different about this person compared to this person. And you wonder whether this person should be on medicines to alter that slope of blood pressure change earlier in life. Of course, those are the types of studies we cannot afford to do because they would require 15 to 20 years of treatment. Now, part of the reason we look at this is that we know that there are substantial vascular changes that occur with age. Perhaps some of the most important ones occur within the central aorta. And obviously, as blood travels away from the heart, the pressure tends to rise. And that's what we see normally in young people who have distensible aortae. But with increasing stiffening of the proximal aorta, we don't see that phenomenon anymore. We see much higher central pressures, which are obviously exposing the brain, the heart, and the kidneys to increasing pressure load, which is not seen in younger people with the more elastic and distensible aortas. So that is why, obviously, there is something about vascular changes with age which are important and may require a somewhat different approach, certainly if you're starting to treat them late, because young people obviously have a very distensible aorta. When it contracts, you can see you have a slow pulse wave velocity, and obviously the return wave returns to the heart in early diastole to facilitate coronary artery perfusion. That is a good thing, and we call that proper ventricular vascular coupling. On the other hand, with more mature individuals who are older, it's much more rapid, and you can see the pulse wave is returning still in systole. This leads to pulse wave augmentation and greater cardiac work and a ventricular vascular mismatch, which ultimately leads to left ventricular hypertrophy and elevated central pressures. And you can see a graphic depiction of that shown here, where in health you have the outbound wave and obviously the end of systole and the return wave, creating what we see here, which is this early diastolic hump of increased pressure to facilitate coronary artery perfusion. That's a good thing to see. But honestly, the problem is with that stiff aorta, if that return wave is occurring during systole, you can see how it amplifies cardiac work, and this leads to increased load and left ventricular hypertrophy and its attendant comorbid and mortal consequences, as well as a reduction in coronary artery blood flow. One has to wonder then how you can define hypertension when you're looking at so many different variables, the young circulation versus the older circulation, and how best to treat it. And that is why I think we need to carefully individualize blood pressure goals. And so if you're asking how to contrast JNC 8 from JNC 7, I'll make it very simple. The JNC 8 team utilized only randomized controlled trials, and when you don't have data, there's not much you can say. Whereas JNC 7 was a non-systematic literature review by an expert committee looking at all of the available data, that is quite a bit different than what was done here. So obviously, the definitions have changed. Here, they looked at the whole picture and looked at the spectrum of disease and created some arbitrary definitions, whereas the 2014 group basically used 140/90 because that's all that had been studied to date. And the treatment goals, as you remember, were quite different. JNC had a 130 target for people with much higher cardiovascular risk, including individuals with coronary disease, diabetes, and chronic kidney disease, whereas 2014 said, wait a minute, we don't have any studies. It's 140 until we know more. And obviously, both recommended lifestyle modifications. I don't think we need to argue about that. As far as pharmacological therapy, JNC 7 was a bit broader, recommending all sorts of different medication classes, whereas 2014 focused on those drug classes with available data, the RAAS blockers, CCBs, and diuretics, and obviously emphasized the doses that were utilized in the randomized control trials. Obviously, the scopes of topics were a bit different because here they looked at lots of different issues that are not evidence-based, whereas here they focused just on the randomized controlled trials. I think some of the important things that were missed here that we're learning today are the importance, for example, of ambulatory blood pressure monitoring and the importance of masked hypertension actually being every bit as risky as sustained hypertension for predicting adverse cardiovascular events. So obviously the review processes were different. The current guidelines are no longer officially sanctioned by the National Heart, Lung, and Blood Institute in the United States. It doesn't mean that they're right or wrong. It just means a different set of opinions, in this case, based on the available information at that time. Now, not to play down the 2014 guidelines, but the SPRINT trial, which I mentioned this morning, will provide a lot of new information. I can't give you the results, even though I know the results, because I am sworn to secrecy. But I will tell you, number one, what we're doing is comparing 140 versus 120 in more than 9,000 people in their 70s. Average age is the low 70s. It's also enriched for coronary artery disease. The fact that the study has been fully recruited and going on for several years now tells you it's safe to lower blood pressure to 120 in 70-year-old people. All right? Otherwise, we would have stopped it. That's the obvious reason. What you don't know is whether or not there will be a benefit of lowering to 120 versus 140. That you'll have to be patient about. We may have some results actually by the time the American Heart Association meeting is presented in November. So stay tuned. You may want to adjust your own medication accordingly. But if you look at the 2014 guidelines, there's nothing wrong with them. They are purely evidence-based. A lot of people got very upset when they saw 150/90 being suggested for people over the age of 60. Well, again, I don't personally agree with that, but that's all the available data we have. And obviously, 140/90 was reset as the target for everybody else, absent available new data. But stay tuned, new data is coming. But appreciate, like the complexity of the cholesterol guidelines and the nice lecture we just heard about earlier, we have the same problem with every different guideline group from around the world choosing various numbers. Let's be fair. You and I are clinical practitioners. We should be choosing appropriate blood pressure goals for our individual patients. Not every patient fits into a guideline. What drugs you use may depend a lot on what they tolerate and what works in an individual patient. But in the back of our minds, we still have this understanding about the epidemiology of blood pressure for both systolic and diastolic. And this is the million-person epidemiological study done by Lewington et al. And it clearly shows that regardless of age, it appears epidemiologically that lower is better for both systolic and diastolic. But what this does not address is the confounding of epidemiology, because you have both treated and untreated people here. And the real question is, if it's easier to treat somebody's blood pressure, let's say down to 120 or 130, does that mean they're different from somebody where it takes more medication to get them down to 120 or 130? Or another way of looking at the data is somebody with a natural blood pressure of 120/70 at less risk than someone who needs medication to get 120/70. So there are reasons why we do randomized controlled trials in order to examine these interesting questions. And of course, the other interesting question is, our patients are all different. This is a nice and colorful slide looking at the percent chance of a CV event in 5 years if you don't have diabetes. Notice the difference between men and women when you look over here at the scale. Red being more than 20% risk in 5 years. Notice the impact of smoking versus non-smoking, and obviously the interrelationship between blood pressure and total to HDL cholesterol ratio. Do all of these people need the same blood pressure target? I would submit no. And these are people without diabetes, and look what happens when I make them diabetic. Again, a very impressive difference. So I would submit to you that we do take care of quite a few different patients out there. They're going to need individualized blood pressure goals. But let's also be fair. Most patients need more than one medication, and this is in large part related to the fact that we start treatment too late. There are also patients that we feel may benefit from lower blood pressure goals. We see more obesity. We see more obstructive sleep apnea, like I discussed yesterday, which may lead to resistant hypertension. And certainly our patients may eat more salt, use nonsteroidal anti-inflammatory drugs. I can go on and on. And so what we're left with is looking at the data with individual medications. And typically a medicine is worth about 10/5. But is that true in everybody? And the answer is no. In some people it's 0, and in other people it's 20. And this is what we call the non-responder-responder phenomenon. The average of 0 and 20 is about 10. And that is why we as clinicians need to individualize our approach, because some medicines are going to work better than others, in large part because we don't know how much of that renin-angiotensin system is involved, that sympathetic nervous system, or that sodium and water handling. But what I tell my patients is what I call the rule of tens. If you're 30 millimeters away from where you need to be, you're probably going to need 3 drugs. Most guidelines have suggested using 2 medicines, preferably as a single pill combination if you're more than 20 millimeters from goal, primarily for simplicity. And there are many different combinations available. All you need to do is walk outside and get some coffee, and you can see everything now is in a different combination. I would submit to you, though, that I prefer using a drug that blocks the renin-angiotensin system, at least as one part of that, and in large part because these drugs are extremely well tolerated. All right? Now, you might argue there may be some vascular benefits as well. And again, I mentioned earlier, they provide a 20% relative risk reduction benefit in people with established heart disease and kidney disease. So for whatever reason, I do think they make sense unless there's a clear contraindication. Plus, we have that data from large-scale clinical trials with the angiotensin-converting enzyme inhibitors providing a 20% relative risk reduction benefit. We have the same thing with the angiotensin receptor blockers showing it, and they've been actually compared head-to-head and have been shown to be therapeutically equivalent in this regard. So I don't know that we need to debate this issue anymore, other than we probably just need to be using these drugs more commonly simply because they are so well tolerated. But many questions still remain. Most people need more than one drug. Sure, you probably should be using a renin-angiotensin system blocker, but do you live longer if you pair that renin-angiotensin system blocker with a diuretic or a calcium channel blocker? I think we've learned that the renin inhibitor doesn't add any benefit over the ACE or the ARB. We've also learned that using 2 RAAS blockers doesn't provide an incremental benefit over using 1. We did do an interesting trial, and I was lucky enough to be asked to be part of the committee to design and put the trial together, called Accomplish. And I like the study because basically in this study, everybody got 40 milligrams of the ACE inhibitor benazepril, and then they were randomized in yellow to either get a calcium channel blocker with it, amlodipine 5 or 10 if needed, and in the bottom red arm, a thiazide diuretic, either 12.5 or 25 milligrams of hydrochlorothiazide, and basically wait 5 years and see if there's a difference in clinical outcomes. Both therapies were quite good in lowering blood pressure. You can see that shown here. Therapeutically equivalent and effective and well tolerated. 130 over 70 is quite a good job for this type of large population of over 11,000 people. And as you can see, we had very high success rates. Nearly 80% of patients got to goal. But when we did examine the outcomes, they were different. And surprisingly so. And we have looked at this data very carefully and cannot yet offer an explanation as to why there was a therapeutic advantage of the calcium blocker with the ACE inhibitor versus the thiazide diuretic. So obviously this kind of study does change guidelines. Now I'm not quite ready to throw out thiazides yet, believe me. They're very helpful, very useful drugs, and they deal with that sodium and water picture I mentioned earlier. But we do need to repeat this kind of clinical trial. How do you decide which to use, a thiazide or a CCB? Could be anything from efficacy to tolerability, or obviously ability to prevent cardiovascular events. And certainly some of the guidelines have suggested now that, and this is the UK NICE guidelines, if you're under 55, use a RAAS blocker with a CCB or a diuretic. On the other hand, if you're over 55, consider that CCB or a diuretic with your ACE. And again, this is kind of the final step 3. These are the therapies that are front and center. Notice, interestingly, the beta blocker is not there. And I'll touch on the reason for that next. There's a bit of a paradox about these drugs. And that is, in older patients, we see more strokes with them compared to other drugs, despite similar blood pressures. We're not really sure why. We also know there are more symptomatology in older patients with these drugs. One of the theories is that these drugs provide less reduction of central systolic blood pressure, which I mentioned earlier is a much more significant issue in older patients. The theory being that the slower heart rate increases the time for pulse wave velocity augmentation. So that may be the explanation behind the paradox, which has been nicely, again, described by Bangalore and colleagues. Here's a big meta-analysis he did, as you can see, in nearly 70,000 patients of similar age and follow-up and baseline blood pressure. Notice blood pressure was reduced quite comparably in each group, but there was a big difference in treated heart rate between the two groups. Now, does that explain what we see here? And that is, in older patients, as that heart rate, treated heart rate is lower, there's paradoxically an increased risk of cardiovascular events. How do we explain that? Again, is it related to greater central systolic blood pressures? We just don't know. But it is, again, not a prospective clinical trial, but nonetheless raises questions as to whether or not we should be driving heart rate down in older patients. And certainly if you compare older versus younger people, you don't really see a augmented risk with lower heart rates in younger people. You primarily see it for stroke and a tendency of a shift to the right predominantly in the older individuals. So there are therapies we have in our armamentarium to treat blood pressure with evidence-based support. And in systolic blood pressure in older patients in particular, I share with you these drugs listed here as being those obviously in the UK NICE guidelines, as well as obviously listed in JNC 14. But some clinical perspective in our conversation today. Hypertension is a lifelong, progressive, largely asymptomatic disease process. Therefore, therapy needs to be simple, safe, effective, and well tolerated. We know with greater complexity of medical regimens that this leads to non-compliance. We also have evidence that as your medicine count goes up and your compliance goes down, so does your increased risk for subsequent problems. And that, I think, is the critical issue, because there are a number of studies that have shown increased risk of myocardial infarction in stroke in people who are non-compliant with their antihypertensive medication. Thus, there is rationale for being careful with our patients and choosing appropriate therapeutic strategies to address that problem of blood pressure, cholesterol, and glucose. As you can see here, as the compliance goes down, the risk of hospitalization goes up. Not a surprise. Which leads me to my last graphic and a summary. This is the question we face in clinical practice. We have all sorts of guidelines which evolve in time, but we have to face individual patients in our office and in our practice. I discussed with you earlier that maybe modifying blood pressure earlier in higher risk patients will result in less vascular conformational changes, particularly if we suspect that mechanical forces are in large part related to the vessel changes over time. This, I think, raises important questions about how early you should start to modify blood pressure. Then the other question is, how low should you go? And this is another important area, I think, of careful individualization. Younger people, you can probably be a lot more aggressive with. Whereas in older patients, you need to be more careful, realizing there's more orthostasis, there are more neuropathic complications, there are more vascular disease, and just as I discussed in my earlier lecture with diabetes, again, people with more advanced disease, vascular disease, you need to be much more cautious with regard to the intensity of therapy. What drugs and doses should you use? Again, my vote is for a renin-angiotensin system blocker, probably coupled with either a calcium channel blocker or a thiazide diuretic, or both if you need it. I think this is certainly supported by the evidence of large-scale clinical trials. And certainly how many medicines will you need depends on the individual patient, their lifestyle, and how early you start to modify the blood pressure. But the bottom line is this is a complicated, lifelong disease process. We have not only the blood pressure to worry about, but also the cholesterol and the glucose, and of course, many other medical problems. So careful individualization is the critical factor. I encourage you all to stay tuned to hear the results of the SPRINT trial, which will likely be presented later this year. Thank you very much for your attention.